Cognitive Behavioral Therapy, Case Study SM by Rachel Zuckerman. SM is a 13-year-old Caucasian female. She has a current diagnosis of major depressive disorder and attention deficit hyperactivity disorder. She currently lives with her biological mother and 12-year-old brother. Her biological father currently resides outside of the home, but he lives close by as of December 2018. Before he moved out, the family reports that there was a lot of scary fighting between mother and father, and biological father jokingly said that it was probably very traumatic and called it verbal abuse. It was very frightening for both of the children, and even though this was scary, SM reports that this is a major stressor for her. She also doesn't see this as a permanent thing because they've often split up, according to her, and he always comes back home. Currently, she is only attending school 2 hours a day with a one-to-one with a retired teacher. It's for social emotional concerns through her IEP. Father commented that this was BS and that her social anxiety was just an excuse to avoid peers because it is difficult for her. SM was hospitalized in the Children's Inpatient Psychiatric Unit for children and adolescents ages 4 to 14. This was in the context of suicidal ideation with a plan, which was to slit her wrists and throat. She told her mother that she wanted to die. After an argument where mother took her phone away and would only let her use it when supervised. This was after finding out that she was having sexual communication online with a 19-year-old male who was supposedly in Europe. She is also no longer in touch with her previous friend group or current friend group after telling her mother that these friends were doing drugs and that she was not. But mother was concerned that this would influence her to do drugs, because they had already convinced her to try juuling, which she has tried a few times. She was also in the emergency room in February of 2019 with suicidal ideation, but denied having a plan at that time. She has currently reported that she has had suicidal ideation with a plan for the past 3 months and long-standing depressive symptoms for the past 2 years. Family psychiatric and substance abuse history. Mother reported during a family meeting that she used cocaine during her pregnancy with SM, but has been clean since SM was born. Child Protective Services was involved with the family due to mother's cocaine use during pregnancy, but that was only till 6 months after SM was born, and there has been no Child Protective Service involvement since then. Father reported that he has depression and he abused opioids but has been clean for 10 years. SM has a 19-year-old half-sister with a history of depression and serious self-injurious behaviors, who lives with her maternal grandparents. SM has a paternal aunt that has paranoid schizophrenia. Every patient that is hospitalized in the Children's Inpatient Psychiatric Unit has a biopsychosocial assessment done with the social worker. This assessment includes homicidality, suicidality, how the child feels safe at home, at school, and in multiple environments. This assessment also goes into detail about the child's family and home life. There are many other aspects to this assessment. Each child also attends 3 to 4 skills groups daily. These groups include coping skills, social skills, and many other topics. Each patient also has individual therapy daily with an attending and then separately with a psychiatric fellow. Often, medical students are also involved in these sessions. Medication management is done with the attending and psychiatric fellow, with med students occasionally. Family sessions occur as needed with the whole treatment team, or if only some are available, parts of the treatment team. The treatment team includes the social worker, the attending, the psychiatric fellow, and often med students or other interns. Safety planning is a very important part of when a child comes home. We often have discussions starting in the first family session regarding safety. For this patient, the mother has reported that she has locked up the medications, eliminated unsupervised phone time, which was a concern for this child due to her sexual communication with a 19-year-old male, and she's increased supervision within the home. These are all important parts of creating a safe space for the child to come home to. We also discussed with the mother locking up all sharp objects before the child returns home, which the mother was in agreement with. Treatment after discharge. Part of SM's plan after she was discharged in February of 2019, she was referred to outpatient services, which included outpatient individual cognitive behavioral therapy and twice weekly girls group, which was based in cognitive behavioral therapy as well. In addition, she has medication management. Part of a social worker's role is to coordinate services and also communicate with current providers. This is to ensure that patients can return to their current services and that they also have appointments scheduled. This can ensure a smoother transition out of the hospital and into their daily routine. Barriers to treatment. Before SM was hospitalized, she only attended 1 out of the 4 sessions of group therapy. This was due to the fact that during the second one, it was canceled, but during the third and the fourth sessions, she told her mom that she didn't feel well. When her mom pressed her for this, she expressed the fact that she was anxious and she didn't feel like going. This affected the momentum of her accessing therapy. Her outpatient therapist reported to us during a phone conversation that SM was reluctant to share a lot of personal information. During her hospitalization, the staff that ran groups reported that SM was hesitant to participate and shy, but when pressed, she would share some information. There are concerns that SM will be reluctant to share in groups and individual therapy, but hopefully with cognitive behavioral therapy, she will be able to access this help. The beginning of cognitive behavioral therapy. Cognitive behavioral therapy is an evidence-based treatment. This means that it is a treatment that is backed by scientific evidence, and that studies have been conducted and extensive research has been done to document on a particular treatment and it has proven successful. Cognitive behavioral therapy was founded by Dr. Aaron Beck in the 1960s. The original Center for Cognitive Behavioral Therapy at Penn served an important training ground for cognitive behavioral therapists. Dr. Beck and his daughter, Dr. Judith Beck, have long wished to establish a new clinical setting that would provide state-of-the-art psychotherapy and training opportunities for professionals statewide and at all levels. In 1994, they established the Beck Institute at its present site in Bala Cynwyd in suburban Philadelphia. What is cognitive behavioral therapy? Cognitive behavioral therapy is a type of psychotherapy based upon the theory that our thoughts affect how we feel and how we behave. Cognitive behavioral therapy is one of the most well-established treatment modalities for anxiety and depressive symptoms in both children and adults. Research has shown that cognitive behavioral therapy is an effective therapy for a wide range of problems, including but not limited to depression, anxiety, severe mental problems, and many other issues. it has been demonstrated to be as effective, if not more, than other forms of psychological therapy. In numerous studies, it has been shown to improve functioning and the quality of life in those who use it. This has been shown through numerous research studies and in clinical practice. Some of the core principles are that psychological problems are based in incorrect or unhelpful ways of thinking. Psychological problems are learned patterns of behavior. People with psychological problems can learn ways to cope with them. This will therefore alleviate their symptoms, which results in a person becoming more effective in their lives. Changing in thinking can be done through cognitive behavioral therapy and recognizing patterns in thinking that create the problems, and developing a better understanding of behaviors and motivation of others. Using problem-solving skills to cope in hard situations and gain confidence in a person's own abilities. This can be done by facing their fears and learning that these catastrophic thoughts of how a situation will go are incorrect or are less extreme than they thought. Role-playing can be helpful for challenging previous ways of thinking and decrease stress for social interactions. Learning calming techniques can also be very helpful in cognitive behavioral therapy. Not all therapists use these strategies. Some just collaborate with their clients to develop understanding of problems and creating strategies to alleviate them. Duration of cognitive behavioral therapy. Cognitive behavioral therapy on average is 8 to 25 sessions, and usually longer if dealing with more complex trauma or depending on the patient's needs. It can be adjusted. Cognitive behavioral techniques and tools. Journaling can help a client understand more about themselves. In addition to talking with a therapist, journaling can be helpful for a client to discover the root of their mood and the source of their distress, and understanding why they respond and have certain feelings about a situation. This can assist in helping a client gather data about in what situations they feel certain ways and why a client is responding in those ways. Understanding and addressing cognitive distortions. This can help to address the vulnerability and tendencies of a patient that has distorted thoughts. Sometimes negative thoughts can be very detrimental in a client living their lives. Next comes cognitive restructuring, which challenges destructive and harmful beliefs and thoughts and restructures them so the client can have more positive interactions and thoughts within themselves. Exposure to a situation that would normally evoke of negative behavior and analyzing why can be very helpful in determining other options for dealing with and interpreting the situation for a client. This can be done through role-playing. This can be done with a therapist or in a group setting to help create healthy ways to behave and in different situations that would normally cause very challenging responses and think about situations differently. Breathing exercises, yoga, and or meditation can be very helpful for a client in helping to calm down and be helpful coping strategies for dealing with stressful situations This slide and the next slide include worksheets that can all be printed for free on therapistaid.com. They require for the client to have a basic understanding of cognitive behavioral therapy and the cognitive behavioral model. The first worksheet, Cognitive Behavioral Example and Practice Sheet, can help a client understand the cognitive behavioral model and record their experiences in this thought log. It requires the client to first come up with the situation, then the thought they had, the feeling that came from it, and the behavior that they exhibited. The first sheet gives an example of how to use the log, and the second one is blank, but unfortunately I was unable to get the blank version on this presentation. The second worksheet is called Challenging Negative Thoughts. This can help clients to address their negative thoughts and use self-talk. All of the questions on these worksheets are provided to help the client consider the situation and their thoughts in a new way and in a more objective way. These next two worksheets will also help clients learn the cognitive behavioral model and understand more about cognitive behavioral therapy. The first worksheet is called Putting Thoughts on Trial. This can help clients examine irrational and potentially very harmful thoughts that inhibit a client from having healthy functioning. The client will take on all of the roles. This includes attorney, prosecutor, and judge to compare evidence for and against just one thought. Like in a real courtroom, only verifiable facts should be taken into consideration and be seen as admissible evidence. Clients will examine their thoughts from multiple perspectives, preferably in a fair and rational manner. The next worksheet is called Core Beliefs. All clients have a diverse set of experiences that have shaped them into the person they are today. Core beliefs are thoughts that the client has that determine how they interpret their experiences. Challenging these negative core beliefs can help clients develop a healthier understanding of themselves and the world they live in. It is important to discuss and educate clients on how their thoughts affect their mood and behaviors in order to help them fully take all the benefits from using these worksheets. Trauma-focused cognitive behavioral therapy is an adaptation of cognitive behavioral therapy. It was developed by Drs. Anthony Manero, Judith Cohen, and Esther Deblinger. The target populations for this therapy are 3 to 18-year-old youth who have significant emotional and/or behavioral difficulties that are related to one or more traumatic events. It can qualify them for a PTSD diagnosis, but it is not required to participate in this therapy. It has been shown to improve the lives of those with various struggles. It can include different types of trauma, from trauma such as wars, traumatic events, natural disasters, and many other events.